Hi everyone, my name is Kelly Poppaw. I teach for Great Lakes Seminars. I teach the Finding Dysfunction class, and I also teach synthesis. Today I'm going to talk to you about the subjective history when you're initially meeting the patient and or for follow-up visits as well. I want to talk a little bit about key questions to think about asking the patient that we probably already are, but we may not understand maybe how to utilize those or the answers that they give us and the why behind that. And I want to talk about 3 key questions that are important to ask every patient, especially when the patient's pain is due to more of a mechanical issue, or you suspect a hypomobility or a hypermobility, and using these questions to know just where to start. So the key questions are the pain intensity, pain quality, and then pain location or referral. So symptoms that are associated with a hypomobility versus a hypermobility will differ in terms of intensity, quality, and referral. So if a patient says that they have greater than 5 out of 10 pain, the pain is sharp and shooting, and it refers in multiple areas, or they have pain in multiple areas at a single joint area, it's more likely going to be associated with hypermobile pain. If on the other side of that, if the pain is less than 5 out of 10, it's dull and achy, and they can really pinpoint like one location, we believe that that sounds like a hypomobile pain area. So it really just helps you to think about, based on those just very simple questions, and utilizing the pain scale, utilizing how they describe their pain, with the quality and or the location, where to start. Should I start treating that local joint area and mobilizing that joint, reducing the myofascial restrictions that are there, and then going into retraining and exercises? Or should I actually start above or below and go global if the pain area sounds like a hypermobility? So if it does sound like a hypermobility, we're suggesting that the driver of the pain probably isn't going to be right there where their pain is. It could be above or below the joint, or even going all the way back to the spine. I think considering all of that, let's take a patient who comes in with an ankle sprain. Obviously, if they're seeing you in a therapy setting versus like an athletic training setting, they may not necessarily have just had that recent injury. Maybe it's been a month, 2 months after the injury, and they're now seeing you. So they're really out of that initial inflammation stage. Usually inflammation sets in for about 3 days up to 21 days, so like 3 weeks top. So really think about that. Their pain, if they're still having pain after that initial inflammatory stage, there's some underlying mechanical dysfunction going on there. And we also have to consider the nervous system and the brain, that their nervous system is still sensitive and still heightened. Obviously, we know that tissue issues heal within a given amount of time. Our body is an amazing machine that helps to heal, as our nervous system. But if people still have pain beyond that initial inflammatory stage, we really need to be thinking, how can we desensitize this area and then treat the underlying mechanical joint, muscle, fascia dysfunctions that could still be there. So again, I utilize that pain scale, the pain quality, and the pain referral, really just to help me know where to start. And then once I know where to start, as I'm working on the physical aspect of their care, the manual therapy or the exercises, I'm also including in some pain neuroscience education with that, and really teaching them about why do they hurt in their nervous system, not just teaching them about the mechanics of their joint and their muscle, again, which is super important to include and just give a well-rounded aspect of care. So thank you so much, and I hope that helps you.